Abhinav to take the stage. A very, very dynamic and shining surgeon. When you see such young surgeons doing so well, you feel so proud of the Indian ophthalmology and what proteges we are giving to the ophthalmic society, not only in the country, but to the world. Dr. Abhinav.
Thank you, sir, for the kind words. And I'll be talking about management of white cataracts and the role of OCT we've been using for the last couple of years. So we know that having a continuous curvilinear capsulaxis poses a challenge in these mature and intumescent cataracts, and the incidence of incomplete capsulaxis is as high as 28.3%. What difference is that there's an absence of red glow, there's an intralencular pressure, there can be an associated zonulopathy, and there's a high risk that the rexes will run out. What we have been taught so far is that you apply the triphon blue, as we've seen, you use a dispersive viscoelastic to flatten the interlenticular space, and you create a 3 mm small rexis, or you make a double rexis, which is called a spiral rexis, or you buy a femtosecond capsulotomy to manage these cases. So another great option was that somebody taught me was do a YAG laser preoperatively so that you minimize the interlenticular pressure, but didn't work so well for me. So this is just a normal video where how we have been taught, we've been doing it, and we do a viscoelastic and we go ahead, make our incisions. I'll go skip through it, I want paucity of time. And this is what we have been doing before. We've been just using a needle endlessly without knowing whether there is fluid or not, and just aspirating the fluid pockets. This is what we were doing before we did this study, and whether or not fluid was there, we never knew. So the biggest question that came to our mind was, how do I know if there is a fluid pocket or not inside the eye? So, and let's not forget, sometimes even when you're doing something right, the Argentinian flag just pops in. And so why does it happen? You have a sudden decompression of the interlenticular space, it pops open, and the splits of the capsule does happen. And it's like pressing a high chamber bag, and if you keep pressing it down and down, it's going to burst open. So there is interlenticular high pressure on both the anterior and the posterior capsule. If you've just touched it, it's going to blow out. So if you look at the image A and image B, you'll see a gross difference. Image A basically show you these hyperreflective pockets which are there in most of these white cataracts. Image B, all the 4 images, also white cataracts, but you don't see any hyperreflective pockets. So what is the difference? Why is it that I am not seeing anything there? So we published this data of ours of role of AIOCMTC4 for safer management of white cataracts. And in our study, we basically had 2 groups. We had white cataracts in both the categories. But if you remember the image A, those were the fluid spaces on the AIOCMTC4. And if you remember the image B, those were the fluid pockets where there was no fluid on the AIOCMTC4. How does it make a difference? You can do this by using a wide to wide angle scan on the Cirrus OCT, which can generate you a 2.9 mm scan of the anterior segment. You can use a pentacam also. You can get the lens status, and the interlenticular space can be assessed. Now this is the group 1. Look at the fluid pocket on the OCT scan. There's a high definitive fluid pocket, and with a 30 gauge needle, you remove this fluid from the subcapsular space, and that's when you realize all the milky cortex is gone, and suddenly there's a brown nucleus that is sitting behind. So this was the group 1. So this has to be gentle, and this has to be slow, can be guided. So you see the large nucleus behind. Now again, let's go to the no fluid pocket. You see the OCT, no fluid pocket, dense cataract, just go ahead straight with the capsulorhexis. There is no fear that comes to your mind. So this helped us, enabled us to be better. And we looked into our results. We had both myopics and hyperopics in our group. What we realized was that we didn't have any, we had 86% completion rate of a curvilinear capsulorhexis. Capsular complications were mostly happening because of the PCR that could have been predictable, and the results were statistically significant. We could go into a nuclear density on the scan on no fluid says we were about 1.199, and with the presence of fluid, we were going to 1.5, because yes, the fluid pocket allowed us to go a little deeper, but we were not seeing the posterior scans, which can now be seen on devices now. And if you look at the reported incidence of complications literature, you will see that 28% is there, failed capsulaxis is 4%, PCR is about 1%, and we had about 13% because small size, the percentage is higher. And the conversion to an ECC is about 4%. So yes, there are chances that you're going to go anywhere. So does it really make a difference? So we looked into the results and we said, okay, let's not tell the surgeon whether fluid pockets are there or not. In one of the subgroups where the surgeon knew about the presence or absence of fluid, the surgical success rate was as high as 86.7%. When the surgeon was unaware whether he's going straight away with a rexis, the completion of a rexis fell down to 64.7%. So just by knowing on an OCT whether fluid pocket is there and you're draining it, you can increase your success rate. Now what is available in literature? Yes, there is definitive literature that femtosecond works, But then again, you have to look at there is a chance of 50% chance of floating rexes. 7.5% had microdegens, and 10% still had incomplete capsulotomy of 1 to 2 clock hours. And this was the Ames group analysis in which they classified these Intumescent cataracts in 4 different categories. The type 1, they said you have a continuous lamella and there is no risk or low risk of having a capsulorhexis extension. You had fluid pockets were similar to our type 1, and this is where the highest chance of capsular extension can happen on the OCT. You have a type 3 in which the lamella is there, but the minimal clefts are noted. So this has a moderate risk of having a capsulorhexis extension. And if you have a type 4, that means the homogeneous capsule, there's a homogeneous nucleus, you will have a low to moderate risk. So this pretty much was well in our favor with what we were talking. Can you actually do it without if you don't have an anterior segment lens? This was a study published by Pujari et al. In which they use a 20D lens, which they put in front of the anterior segment OCT, and they were able to classify these spaces the same as we were doing it with the the lens of the eyes. Now the Blanco puncture was something simpler. The Blanco was that before you do make any incision, he said use a 30 gauge needle before you make any incision so that you don't decompress the anterior chamber, and it causes a much more easier walking out of the fluid pockets. This was published by Rohit, and this is one of the most important signs that you have. If you've had a posterior capsule arch, if you're anticipating it, the inverted capsule will tell you whether or not the edge is going to go off or not, and if the edge is inverted, there's a high chance of PCR. So I will not put into my video. This was another technique by Dr. Kamal sir. I borrowed his technique. I'll just slowly, I'll fast.
We start by staining the anterior capsule or putting viscoelastic.
You have to make a reverse T incision before you make it.
We again instill viscoelastic, and then we puncture the anterior capsule in a linear manner and aspirate the interlenticular fluid, thus reducing the interlenticular pressure. Once this is done, we again instill viscoelastic into the anterior chamber, thus putting pressure onto the capsule and expressing more
So this is a reverse T in which they use the reverse T to complete the capsule further.
To create a
I
single
won't show it further. So again, why you should use the OCT? You have the advantage. You can see the fluid pockets. You'll be a happy surgeon. You won't need to worry about the iodine flag sign. And in conclusion, use the 30 gauge needle. It helps you a better removal of the fluid. AS OCT can show you the fluid pockets and decrease the chances of capsular tears. Thank you.
Thank you, Dr. Abhinav, for your excellent presentation. Surely, I think it make difference.
Yes, sir.
And make the surgery also and easier, and complication rate will be down.
Yes, it makes you more confident actually.